Good morning, faculty, distinguished guests, ladies and gentlemen. Welcome to the European University Cyprus School of Medicine for the second day of 12th International Biomedical Scientific Cyprus Congress. We would like now to call upon chairs for the next session. Oral presentation of selected abstract. Would Dr. Panayoti Christodoulou and Dr. Charalambos Michailidis please come to the stage for presentation 1 to 4, and Dr. Andreas Yalourous and Dr. Charalambos Philippou for presentation 5 to 7. Thank you.
Good morning, everyone. I would like to invite Mr. Houdis Georgios Theodoros from the European University Cyprus, who will present the presentation with title Unimportant Lung Lobectomies for the NSCLC, a Changing Trend in Operating Technique.
Thank you. Dear professors, dear colleagues, dear eminent faculty, dear guests, my name is George Theodor Houdis, and I'm going to present you my assignment, which is based on uniportal lung lobectomies as a treatment method for non-small cell lung cancer. So as an introduction, we know that lung cancer is the second most common malignancy in the world. It's differentiated as small cell lung cancer and non-small cell lung cancer. It accounts for about 18% of all cancer deaths, and 1 in 3 patients will suffer from metastasis apart from the lungs. So, for the lung cancer staging, at the initial stages 1, 2, and 3A, the primary treatment method is surgery, while in more advanced stages, such as 3B and 4, where we have further involvement of the lung parenchyma and infiltration of the tumor, we prefer to use targeted methods such as chemotherapy and radiotherapy. Now, more specifically about non-small cell lung cancer, which is the most frequent form of lung cancer, we have several subtypes, such as adenocarcinoma, squamous carcinoma, and large cell carcinoma, as well as other rare types. The most of the patients are diagnosed at a more advanced stage. The average survival rate is 23 to 27% at 5 years. And the 5-year survival rate at stage 1, which is localized, is 63%, so that's why surgery is the primary treatment method. At the stages 2 and 3, where the tumor is more regional, we prefer the combination of therapies, while at stage 4, where we have more distant tumors and infiltration, we prefer only targeted therapies. So now, for the lung resection operation, we have several subtypes. We have the wedge resection, we have the segmentectomy, we have the lobectomy, and the pneumonectomy. So it's according to the extent and the specific site of the tumor and its subsequent vascularization in order to decide to which operation we will proceed. So, for the types of lobectomy operations, we have the open lobectomy, which is achieved through a traditional, relatively large thoracotomy. The VATS lobectomy, which is performed through the insertion of ports in the intercostal space, and we insert our instruments, our camera, and our scissors and our forceps, as I will show you later. And on the robotic-assisted thoracoscopic lobectomy, we perform the operation through the assistance of robotic arms. For the anesthetic considerations, they are the same as every other operation. In our case, in our surgeries specifically, we use the double lumen tube, which allows us to hypoventilate the one lung and allow the normal function of the other lung, so as the patient could be able to oxygenate his tissues. The video-assisted thoracoscopic surgery is defined as a minimal invasive surgical procedure which is used to diagnose and treat illness or injury to the lung on other organs in the thoracic cavity. So, as I mentioned, we used trocars, which we place through small incisions, where the surgeon gains access from the intercostal space, and we have our endoscope, which is a tiny camera, and our surgical instruments, which we use in order to dissect, cauterize, staple, and drain. On this slide, on the left picture, you can see the anatomic structures that we are key interested in. So we have the pulmonary artery, the pulmonary vein, and the bronchus. On the right picture, you can see that we have there is the placement of the ports, how we think in order to reach this site and make it easy for us and also safe. So on the left here, you can see the camera. It's a 30-degree camera, our thoracoscope. And on the right, we have the surgical forceps. We also have dissecting devices and energy sealing machines, and our surgical staplers, which can cut the tissue. So here I have a video. You can see we are on the hilum of the lung. So the surgeon here is trying to dissect the lung parenchyma and the peripheral tissue in order to reach the pulmonary artery, the pulmonary vein, and the bronchus, as I mentioned. As you can see, it's a very bleedy operation generally. On the left image, I have a lung wedge resection operation, and on the right image, I have a lung lobectomy operation. On this slide, you can see the position of every person inside the OR. You can also see the characteristic position of the patient when it's on the thoracotomy, for thoracotomy incision. So now, specifically for uniportal lung lobectomy, to define it again more specifically now, it's the minimal invasive lobectomy that is performed through keyhole incisions using a tiny camera and surgical instrument. You can see again how we place our instruments and the anatomy of the area. So, through VATS, we can perform all the operations inside the thoracic cavity, as well as minimal invasive cardiac surgery. The benefits of it, first of all, that it's minimal invasive. We have a panoramic view, enhanced surgical precision, and for the patient that it involves small scars, less pain, less rehabilitation time, and shorter hospital stay, and generally reduced complications. So the complications are the same as every other operation in the thorax. What I want to note is that we have a specific complication, which is the conversion to open surgery. So there is a very small probability that we may need to open the patient if things go wrong immediately, because you can understand that in the thorax we have major vessels. So if something goes wrong, for example, if we have an uncontrolled hemorrhage, we need to open the patient immediately. Our experience is ranged for 3 years. So we performed 20 uniportal VATS lobectomies to 20 patients. 16 were males and 4 were females. We performed 8 left upper operations, 4 left lower, 4 right upper, and 4 right lower. All of them, as you can see, were heavy smokers. The operative time ranged from 400 minutes to 300 minutes. For the management of the post-operative pain, we used epidural analgesia, paravertebral block, intercostal nerve block, and intravenous analgesia. I need to say that we had one operation, which was a redo operation actually. So it was a redo operation after 20 days, and it was very complicated, the operation. So after 9 hours of surgery, we decided to open the patient due to a hemorrhage, which was actually controlled. For the histological tests of our patients, we had 10 squamous cell carcinomas, 6 adenocarcinomas, 1 Hodgkin lymphoma, 2 large cell carcinomas, and 1 neuroendocrine cell carcinoma. So I have a video here again. So this is the pulmonary artery. The forceps from the behind is called the snake, while the forceps in front is called the peanut. and you can see how the surgeon is trying in order to dissect it. So imagine that if something goes wrong here, it will take a lot of time to fix it, and it will be life-threatening. Again here, you can see that we have the bronchus. This is a stapler for the bronchus, and this red thing is called a vessel, and we use it in order to manipulate the structures that we want to dissect. So now, I also have some pictures with my team from the Athens Naval and Veterans Hospital here. And in conclusion, lobectomy operations are very basic and significant operations, but despite being difficult, they can be completed minimally invasive with less pain, fewer complications, and better quality life for the patient. The decision-making process of the operation should focus on patient's overall health, the extent of the disease, the type of the procedure, the surgeon's expertise, and the hospital resources. And because it's an issue of competitiveness and advertisement, I believe that it's very important to mention that from my personal experience, a VATS procedure can be modified significantly fast to an open formal thoracotomy, much more faster than robotic-assisted thoracoscopic surgery for safety reasons, because we need approximately 15 minutes to remove the robot from the OR in order to operate, to gain access and operate on the patient. And we don't have this time in the operations of the thorax if something goes wrong. Okay, we must act immediately. Thank you very much.
Thank you very much. In the interest of time, we won't be able to take any questions now, but anyone has a question can talk to the speakers later on after the session. Okay, so we're moving, thank you very much. We are moving on to the next presenter for today, Athanasia Zambeta from the Cosmetic Derma Medicine Clinic, Nicosia. The title of her presentation is Biology of Skin Aging and Sun Damage.
Hello, good morning. I'm Dr. Athanasia Zambeta. I'm dermatologist venereologist, and today we will discuss about biology of skin aging and sun damage. Our skin is the largest organ of our body, and it's a unique biologic universe with its own blood, innervation, muscle, immunity. It works as an endocrine system with its own psycho-emotional reactivity, and of course, it is the environmental barrier that protects us. Let's talk now about aging. It is a total of progressive physiological changes in an organism that lead to senescence. It's actually the decline of biological functions and the organism's ability to adapt to metabolic stress with time. Here it is a very interesting picture that contains all 9 hallmarks of aging as were described in 2013, respective article published in Cell magazine. These are the genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, deregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, and altered intercellular communication. Actually, there are 2 theories about aging. One theory says that aging is a preordained process that is genetically determined, and it is called intrinsic aging. This theory is supported by telomere lengths, actually the last portion of a chromosome that gets shortened after every cell cycle. As this telomere gets shorter and shorter, it gets in a critical length, and after that length, apoptosis is starting on the cell. There is also one other theory about aging that says that aging is largely due to cumulative environmental damage. This is the extrinsic aging that is caused by reactive oxygen species that affects some cellular defense systems and reduces the activity of antioxidant enzymes and non-enzymatic antioxidants. In this picture, we see that skin aging is both intrinsic and extrinsic. We will talk more elaborately about these 2 types of aging. About intrinsic aging, it is a cellular aging and shortening of telomeres. It is caused by mutations of mitochondrial DNA, of genetic mutations. It can also be caused by decrease of estrogens and androgens. That's why in menopausal women, when we have excessive excessive reduction of sex-specific hormones, we experience deterioration of skin structure and moisturization of the skin. How skin with intrinsic aging looks like. We experience flattening of the epidermis, loss of subcutaneous fat, and reduction of dermal mast cells, reduction in the production of melanin, of collagen and elastin, and sebum. And now let's talk about the extrinsic aging, when the most important environmental factor of extrinsic aging is photoaging. Ultraviolet radiation is divided into two types, UVA and UVB. UVA radiation is absorbed by cellular chromophores and produces ROS, so causes more increased risk for skin cancer. And UVB radiation is responsible for sunburn, tanning, and causes a direct damage at the DNA through inflammation and immunosuppression. In this picture, we see how UVA and UVB exposure produces this reactive oxygen species and induction of matrix metalloproteinases. ROS and MMPs cause degradation of the extracellular matrix and inhibition of neocollagenesis. So we see destruction of the elastic fibers and the formation of wrinkles. In general, UV-induced damage lead to non-melanocytic skin cancer, which is the main problem in photoaging. In this picture, we see how photoaging affects each cell in our skin. And now let's discuss the clinical appearance of intrinsic and extrinsic aging. Intrinsic aging makes our skin look uniformly pigmented with rare hair follicles and gentle sweat glands and sebacous glands. The skin gets less elastic, fine wrinkles appear, and the expression lines are more exaggerated. On the other hand, photoaging causes coarse wrinkling in our skin. The texture gets rough, we experience sallow complexion with mottled pigmentation, there is loss of skin elasticity, we start to see some fine telangiectasias on the skin, there is increased fragility, purpura formation, impaired wound healing, and of course benign and malignant growths. In the following pictures, we will see some aesthetic concern about photoaging, but the most important concern is about medical complications. On the first picture, we see some precancerous lesions, which are called actinic keratosis, and on the next pictures, we see skin cancer, both basal cell carcinomas, squamous cell carcinomas, and on the last picture, there is a melanoma. This is a viral picture at the social media. It's, here we see a truck driver with 28 years of working, and we see how the cumulative UV radiation has damaged the left side of his face because he drove from this side of the road. The important thing about photoaging is not only the cumulative UV radiation from the sun, but also the skin type that we have. People with fair skin tones, 1 and 2, according to Fitzpatrick, experience atrophic skin changes, focal depigmentation, epidermal atrophy, and ephthelites. But people with darker skin types will see on their faces diffuse irreversible hyperpigmentation, leathery appearance, and deep wrinkles. Apart from photoaging, there are also other environmental factors that cause extrinsic aging. These are tobacco smoking, infrared radiation, which is actually half of total incident solar energy that we receive, and pollution. Pollution causes damage which is worsened by solar radiation. UVA radiation combined with environmental pollutants like cigarette smoke can increase the risk for skin cancer. So how can we prevent or even reverse skin aging? Of course, we should use lots of sunscreen. There are two types of sunscreen, inorganic and organic ones. Inorganic reflect, scatter or absorb UV radiation depending on the particle size and the wavelength of the light. They do not cause any skin irritation or skin sensitivity, but they cannot penetrate into the layers below the stratum corneum of the epidermis. And there are also the organic ones which absorb UV radiation, whereby the agent's electrons reach an excited state. Last but not least, we can prevent or even reverse skin aging with the use and consumption of non-enzymatic antioxidants like ascorbic acid, coenzyme Q10, vitamin E, niacinamide, B-carotene, and of course polyphenols like green tea, polypodium, leucotomos, and silymarin. And lastly, let's have a take-home message. How can we protect ourselves in order to prevent skin aging? At first, we can drink a lot of water, eat good food, sleep well, exercise regularly, reduce stress, if possible, and use SPF. Thank you very much.
Thank you very much, Dr. Zabeta. It was very interesting. So we will move to the next presenter. Thank you once again. Dr. Maria Zandi from the Biostatistic Unit of the Cyprus Institute of Neurology and Genetics will present the analysis of more than 400,000 women, provides case control evidence for BRCA1 and BRCA2 variant classification.
Good morning. I would like to thank the organizing committee for giving us the opportunity to present our work, which is on the analysis of more than 400,000 women to provide case control evidence for BRCA1 and BRCA2 variant classification. So a brief introduction. So breast cancer is the most common malignancy, affecting around 8 million cases the last 5 years. There are many risk factors contributing to an increased risk of the disease, including age, sex, lifestyle factors, sociocultural factors, reproductive and hormonal factors, as well as family history. So around 5 to 10% of all breast cancer cases are familial cases of the disease caused by predisposing variants in the germline DNA. So BRCA1 and BRCA2 are one of the high penetrance breast cancer susceptibility genes, conferring 5 to 10 times increased risk of developing the disease. Genetic testing for these genes is offered to individuals who have a higher likelihood of carrying a pathogenic variant, for example, individuals diagnosed at an early age of onset or with many family members with the same cancer. So genetic testing identifies variants, and these can be classified into 5 classes. The benign and likely benign ones, which are the ones that do not require any clinical interventions. The likely pathogenic and pathogenic ones, the ones that require clinical interventions, such as closer surveillance at an earlier age, prophylactic surgeries, chemoprevention, and targeted therapies for the individuals that already have cancer. However, we have an intermediate class called variants of uncertain clinical significance, for which, unfortunately, we don't have enough evidence to conclude to a variant class. Variant classification is dependent on multiple lines of evidence, and it's performed according to the ACMG-AMP guidelines. And these evidence include the variant's nature and position, results from functional studies, the variant co-occurrence with another pathogenic variant, disease co-segregation within families, family history, and of course case control data. So these evidences are preferably measured as likelihood ratios and then weighted to co-strain categories, which are then combined together to provide the variant classification. So case control variant frequency is currently used under the ACMG-AMP guidelines and the PS4 criterion, which states that using logistic regression, an odds ratio higher or equal than 4 and a confidence interval not including 2 can provide strong pathogenic evidence. However, using logistic regression, we cannot derive any criteria for benign evidence. That's why we tried to develop the case control likelihood ratio method, which actually uses a survival analysis framework and compares the likelihood of the distribution of the variant of interest between cases and controls under the hypothesis that the variant has similar age-specific relative risks as the average BRCA1 or BRCA2 pathogenic variant, compared to the hypothesis that the variant is not associated with an increased risk of the disease. So, in collaboration and equal contribution with my colleague Denis O'Mahony, we analyzed 3 large data sets: the Bridges dataset, the Bridges panel sequencing data from the Breast Cancer Association Consortium, the panel sequencing dataset from the Carriers Consortium, and whole exome sequencing data from UK Biobank. We had in total around 97,000 female cases and around 305,000 female controls, and a sequencing data from around 11,000 BRCA1 and BRCA2 variants, of which around 7,000 with encoding sequences plus minus 5 base pairs flanking the exons. So we used its data and analyzed it using the case control likelihood ratio method and logistic regression. And following many validation steps, we finally derived case control evidence for 686 BRCA1 and 1,035 BRCA2 variants. As you can see from the pie chart, the majority of these variants were variants of uncertain significance in ClinVar or variants with conflicting submissions. So more details on the result. We derive evidence in favor of pathogenicity for 116 variants, whereas evidence against pathogenicity for 488 variants in BRCA1. Using logistic regression, unfortunately, we derived the PS4 criterion only for 13 variants. Now, in terms of the classification of these variants, you can see on the right-hand side that we have many variants VUS for the ones assigned evidence in favor of pathogenicity, and we have a 95.4 concordance with ClinVar. On the left-hand side of the chart, you can see for the ones that we assign evidence against pathogenicity, we have more than 50% VUS, and we show a 99.1 concordance with ClinVar. For the 13 variants assigned the PS4 criterion, only 1 was VUS, and the remaining 12 variants were classified as likely pathogenic or pathogenic in ClinVar. So now, in terms of the consequence of these variants, for the ones assigned evidence in favor of pathogenicity, the majority were protein truncating variants, followed by missense and synonymous. For the ones assigned evidence against pathogenicity, the majority were missense, followed by some synonymous, intronic, in-frame, and some protein truncating variants. Whereas the 13 variants assigned the PS4 criterion using logistic regression, 10 were PTVs and 3 were missense variants. Similar results for BRCA2. We derive evidence in favor of pathogenicity for 150 variants, whereas against pathogenicity for 701 variants. Using the logistic regression analysis, we only reached the PS4 criterion for 18 variants. In terms of the classification of these variants, I guess we have a large number of VUS. We showed a high concordance with ClinVar. For the 18 variants assigned the PS4 criterion, only 1 was VUS, and the remaining 17 were variants classified as likely pathogenic or pathogenic in ClinVar. And in terms of the consequence, again, we managed to provide case control evidence for a large number of protein truncating variants, missense, synonymous, intronic, and in-frame variants. So to briefly discuss these results, up to date we only had case control evidence for only 111 BRCA1 and BRCA2 variants. Our results strongly correspond with ClinVar classifications, can be used for evaluating the consistency of other findings and other lines of evidence for variant classification. We managed to cover 21.3% of the ClinVar curated variants and 23.5% of the ClinVar unclassified variants. And finally, as you can see from the chart, we managed to provide case control evidence for 785 unclassified variants. Finally, this is a collaborative work. I would like to thank collaborators within BCAC, Carriers, and Enigma Consortium, of course, UK Biobank, my supervisor, Dr. Kyriaki Mihailidou, who supervised this work, my colleague, Dennis Mahoney, who equally contributed to this analysis, and of course, all of the collaborators who contributed to the development, application of the method, and analysis of these results. Thank you so much.
Thank you very much. So our next speaker is Orsalia Doudouzaf from Imperial College London School of Medicine. The title of her presentation is A Step-Up Approach for Pre-Operative Malnutrition Assessment in Patients Undergoing Surgery for Gastrointestinal Cancer.
We have the wrong slides. The slides are wrong. The slides are wrong. Yeah. The slides are wrong.
Wrong. In the wrong.
The wrong position. Good morning. My name is Orsalia Doudouzaf, and I'm very happy to present the work of my team on a step-up approach for the preoperative malnutrition assessment in patients undergoing surgery for gastrointestinal cancer. Malnutrition in gastrointestinal cancer surgical patients is a very important issue, as we see that 1 in 2 patients undergoing surgery are presenting with malnutrition status before their surgery, and that has a large impact on their survival, recovery, functional status, and systemically on hospital stay. On assessment, there is an availability of several tools to assess malnutrition. However, there is an important and considerable variance in the reported diagnostic and predictive metrics. This is why we have identified the research gap in their comparative diagnostic and predictive accuracy, which we felt it was poorly established and we wanted to delve into further. And therefore, we wanted to see how these different metrics might differ between the different tools available. There are different tools that we have. The first 2 are malnutrition assessment tools, and the latter are scorings of nutrition. And they take into account different aspects. We see that PGCSA, for example, is for triaging and has a multitude of patient, professional, and global assessment key criteria, whereas a scoring system as the CONET take into account lab-based parameters and are more robust into establishing the nutrition state rather than a malnutrition risk. Therefore, our aim has been to evaluate their predictive accuracy for post-operative outcomes in patients operated for gastrointestinal cancers. We have developed a cross-sectional bi-center observational study, which ran from March 2022 to October 2023 in 2 major university surgical departments of Athens. We have enrolled and studied 480 patients undergoing surgery for either colorectal, hepatobiliary, or upper GI cancer. And we used all those tools before their operations and analyzed their performance metrics of sensitivity, specificity, a positive and negative predictive value, and area under curve with regards to 5 post-operative outcomes, including overall complications, major complications under the Claventino classification, length of stay, advanced disease stage, and mortality. And this was for the entirety of their hospital stay and for 30 days post their surgery. Our results, first, with regards to malnutrition risk identification, have identified that higher rates were seen with PG, SGA, and GLIM, in contrast to lower rates with CONAT and GNRI, and with the only exception for hepatobiliary cancer, when GNRI was found to identify a much greater risk in a larger proportion of our cohorts, and it was the only tool to also follow an inconsistency with regards to this cancer type. And when moving on to their comparative predictive performance metrics, we have seen that the image was reversed with CONAT and GNRI, demonstrating a very high specificity to lengths of 80 and 90% for predicting overall complications, length of stay, mortality, and advanced disease stage. And CONAT specifically reaching specificity of over 97% for colorectal and upper GI cancer. However, owing to the lower specificity, we have also seen that PGCSA and GLIM, we had better sensitivity, but lower specificity, followed the completely different image. On the further analysis of the performance metrics, we've seen that the CONAT criteria were the ones presenting with the highest measures of specificity and had even a 100% positive predictive value of most outcomes, which was consistent across all cancer types studied, which means that it's a very valuable tool for identifying non-at-risk patients and decreasing false positives. On similar lines, GNRI with a very high specificity as well, but with a lower sensitivity, means that it might miss some at-risk patients which CONAT wouldn't. And then on GLIM criteria in PGCGSA, these are tools that have moderate to high specificity and lower sensitivity, which means that they're most useful in excluding non-at-risk patients with a considerable risk of including false negatives, however. And because they are very significant in having a very higher sensitivity in mortality, they do remain very valuable for patients who are at a recognized risk. And with regard to our findings for area under curve, it was moderate for all the tools studied. That's a table that provides a comparative summary of the key performance metrics, for which we have felt that the most appropriate recommendation of our research to put this into the clinical context was the recommendation of a step-up approach. So currently, under the most international guidelines that are present for malnutrition assessment of oncological patients, it's recommended that GLIM criteria take first place and then another criteria. So there isn't a clear and direct indication of which criteria should follow GLIM. And based on what we have seen from our comparative analysis, we propose that GLIM or PGSGA can be used as a primary step to identifying all those who are at high risk, so also excluding those who are at low risk, because that's also very important in the context of oncological surgical patients to ensure that we perform a fair resource allocation and also that timely operations take place without putting on a further risk and oncologic burden on patients who do not present with a high malnutrition risk. And then on a second basis, for the patients who have a recognized malnutritional status, we can perform CONAT and GNRI. So this would be as well in line with guidelines that are present, but giving a further direction, as they are much more specific to and predictive of postoperative complications, which if recognized, we can act upon clinically. So as future directions, and given what we have found and what we appreciate in the literature, we believe that it's very critical that in the next years we validate the accuracy of those metrics across clinical settings and patient populations. And we continuously develop our tool assessment tools in order to refine their cutoffs and provide a better certification of patients. And finally, the inclusion of nutritional assessment into the broader perioperative care framework, which is very important, as we've seen that it's critical to establish optimal clinical outcomes, but also to ensure that we are identifying the risk appropriately and acting upon it. Our conclusions: CONAT and GNRI exhibit high specificity and therefore hold value in confidently ruling out non-at-risk patients for postoperative complications and minimizing false positives. However, tools such as GLIM and PGCGA, which have superior recipient sensitivity with slightly less specific, are more effective at identifying those at risk, especially for mortality. Therefore, owing to their comprehensive assessment criteria, they can complement high specificity tools in a balanced approach to enhance overall screening efficacy. A step-up approach is recommended, starting with PGSGA and GLIM, as also suggested under current guidelines, but then followed by a complementary evaluation of CONAT and GNRI, which can further guide us in how we triage nutritional intervention and how we prevent postoperative complications for those at high risk of them in specific. And this approach remains down to further evaluation and validation in future studies to be tested across different clinical settings, cancer populations, patients, ages, with more to come on a very exciting field on how nutrition can truly revolutionize surgical oncology and progress of oncological patients. Thank you for your attention.
Thank you very much.
Good morning. The next presenter will be Emilia Grasu from the European University of Cyprus, and she will present the presentation with the title Resting Heart Rate and Mortality Risk in Hypersensitivity Patients with No Atrial Fibrillation, adjusted for cardiorespiratory fitness and B blockade.
Good morning to all. My name is Emilia Maria Grasu, and in collaboration with Dr. Kokinos, Dr. Vaselis, Dr. Grasus, and Dr. Pitaras, today I'm going to present to you the correlation of resting heart rate and mortality risk in hypertensive patients with no atrial fibrillation, adjusted for cardiorespiratory fitness and beta blockade. So, to start off, the European Society of Hypertension guidelines recognize resting heart rate as an independent cardiovascular risk factor for hypertensive patients. Furthermore, it is well known that increased physical fitness significantly influences both overall mortality rates and specific resting heart rate levels, so much so that studies have shown that regular exercise lowers resting heart rate and is associated with improved cardiovascular health. However, despite its importance, the relationship between resting heart rate and mortality risk remains inadequately explored till this day, particularly when adjusted for cardiorespiratory fitness, age, comorbidities, and medication usage. So this extensive study evaluated resting heart rate and mortality outcomes in a large cohort of more than 400,000 hypertensive patients with a diverged mean age of 62.5 years old. Each participant completed a standard exercise treadmill test, which serves as a reliable tool for assessing cardiovascular fitness and endurance capacity. Key exclusion criteria for this study involve the presence of atrial fibrillation or any overt heart disease. These criteria were crucial to maintain the integrity of the data collected during the exercise treadmill test, thereby ensuring that underlying heart conditions did not skew mortality risk results. Participants were categorized into 6 distinct resting heart rate categories defined by 10 beats per minute intervals, ranging from less than 60 beats per minute to greater than or equal to 100 beats per minute. This systematic categorization allowed us to observe more clearly the comparisons across different heart rate elevations. Moreover, the study implemented extensive statistical adjustments for a multitude of variables, including age, body mass index, pre-existing cardiac risk factors, exercise capacity, and medication effects, particularly beta blockers. As I mentioned before, and as you can clearly see in this slide, the sample included more than 400,000 patients with a wide range of heart rates and varying medical characteristics, reflecting therefore the real-world hypertensive populations. To be more specific, the average age was around 62 years old, and the study participants had an average weight of 89 kilograms and an average BMI of 30. Also, the observed average resting heart rate was 75.4 beats per minute, indicating a trend towards elevated heart rates within the cohort, reflective of potential underlying cardiovascular concerns. And lastly, the study reported significant comorbidity prevalence, including smoking habits and diabetes, both of which exacerbate cardiovascular risks and mortality outcomes. So, the median follow-up duration for mortality data collection was approximately 10.6 years, so around 11 years. Throughout this period, a total of more than 107,000 deaths were recorded, providing a robust and comprehensive data set for analysis. The analysis revealed that mortality risk escalated by 15% for individuals with a resting heart rate of 80 beats per minute or greater, and significantly increased by 41% for those exhibiting rates of 100 beats per minute or higher. More importantly, as you will see in the next slide, these mortality risk trends were consistent across various age groups and were observed in patients on beta blockers, indicating therefore that elevating resting heart rate is a pervasive influence on mortality risk across diverse patient demographics. As I mentioned before, here we can clearly see the 15% increase in mortality risk for individuals with a resting heart rate of 80 beats per minute or greater in the dark blue bar, and also the 41% increase in mortality risk for individuals with a resting heart rate of 100 beats per minute or greater in the light red bar. Lastly, here it's easy to understand and observe that these mortality risk trends were consistent across various age groups, and more specifically for those that are 60 years old, for those 60 to 69 years old, and for those who are older or 70 years old. I would like to also point out that these findings achieved statistical significance, as you can see by the asterisk at the top of the slide, underscoring therefore the reliability and relevance of the data. Notably, we observed that for every 10 beats per minute increase in resting heart rate, there was an associated 11% increase in mortality risk, even after adjusting for various confounding factors such as age and exercise capacity. Moreover, it was observed that analysis without the inclusion of fitness data consistently overestimated mortality risk. This finding highlights the importance of incorporating exercise capacity into cardiovascular risk assessments to achieve a more holistic understanding of mortality risks among hypertensive individuals. Detailed analysis provided adjusted hazard ratios for mortality risk associated with multiple variables, including age, resting heart rate, body mass index, smoking status, diabetes, and exercise capacity, measured in metabolic equivalents, METs. Each variable was documented with respective coefficients and significance levels, illustrating the complex interplay of these factors in predicting mortality risk. Non-adjusted hazard ratios for mortality risk were calculated based on resting heart rate categories in subjects receiving beta blocker treatments, utilizing initial rates of heart rate under 60 beats per minute as a baseline control group for accurate comparison. Looking at this table, we can clearly see that the risk is lower when adjusted for METs in comparison to those not adjusted for METs, highlighting therefore the importance of physical fitness in cardiovascular health. To sum up, we noted a progressive increase, 15% to 41% in mortality risk, with increased resting heart rate at more than or equal to 80 beats per minute in hypertensive patients with no atrial fibrillation, and that the association was independent of comorbidities and medications. Furthermore, we noted approximately 11% increase in risk for each 10 beats per minute, and that the mortality risk was consistently overestimated when fitness was not considered. Thank you for your attention.
Thank you very much. The next speaker will be Fanny Kusuyani from the Department of Pharmacology, Faculty of Medicine, University of Thessaly, and she will present a presentation with the title of Studying the Potential Role of TMEM97 PGRMC1 sigma 2 receptor in pancreatic ductal adenocarcinoma development.
Hello, thank you. Good morning to everyone. I'm Fanny Kusuyani. Today we'll present you our work with the title The Potential Role of TMEM97 PGRMC1 sigma 2 receptor in PDAC development. Let's start with a short introduction part. Sigma proteins were thought to belong to the opioid family, receptor family, until 1976, and later they were identified as an independent class of receptors, divided into two subtypes, sigma 1 and sigma 2. They have high affinity for DTG and haloperidol members of non-opioid family, and their distinction was firstly happened after silencing of the gene of sigma 1 receptor, which showed the existence of a different gene of sigma 2 receptor. TMEM was lately characterized as the sigma 2 receptor. It is a near resident protein involved in homeostasis of cholesterol, and also it acts as an NPC1 interacting protein. PGRMC1 previously was thought to be the sigma 2 receptor, but it's not validated anymore. There is a mystery between the theories where studies with sigma 2 ligands didn't show the nuclear localization of the sigma 2 receptor. So Hugh and his team suggested that the binding site of sigma 2 receptor may belong to PGRMC1, so they may act as a complex. That's why we aimed here to study both the single size RNA, silencing of PGRMC1 and TMEM97 separately, and in the double silencing in the same time. Siramacin is the basic sigma 2 selective agonist, ligand of sigma 2 receptors, which through bibliography has shown a variety of anti-cancer properties, both in vitro and in vivo. So the aim of this study is to see the role of TMEM97 and PGRMC1, and subsequently the role of sigma 2 receptor in the carcinogenesis of PDAC, and moreover, the role of these receptors in the anti-cancer activity of siramacin, as the literature suggests that some sigma 2 ligands act independently of the existence of sigma 2 receptors. The methodology we used is shown in this slide. I should highlight here that the cells that we use are a primary ex vivo pancreatic cancer cell population, which we isolated in our lab using patient-derived xenografts. In order to study further and to clarify the role of TMEM97 and PGRMC1, we transfected the cells with siRNA. Firstly, we wanted to see the efficacy of this siRNA that we used, so we performed the Western blot to investigate the protein levels of TMEM97 and PGRMC1. The results here show that the silencing was quite efficient for TMEM97 and PGRMC1, but it was not quite efficient when we attempted to silence both proteins in the same time. Next, after the successful silencing of the receptors, we tried to see the effect of siramacin, the ligand, on these primary cells. The results here shows that siramacin can inhibit the proliferation of the cells at low micromolarity levels, as you can see also in the table. And generally, here you see that the presence of TMEM97 and PGRMC1 is not important for the proliferation, as you can see the concentrations that provoke 50% of growth inhibition are approximately estimated to be the same for all the conditions tested. Next, we wanted to see the effect of ceramycin and the silencing of this role on the colony formation using clonogenic assay. While TMEM seems not to affect the colony formation of these primary pancreatic cancer cells, PGRMC1 seems to affect the colony formation, so it might have an involvement in the aggressiveness of PDAC. Moreover, through this procedure, we saw that ceramycin induces a reduction in the number of colonies in a dose-dependent manner without any connection with the presence of the receptors. Subsequently, we wanted to check the impact of ceramycin on the cell cycle of these cells, expressing different levels of TMEM97 and PGRMC1. Ceramycin in the wild-type cells, without silencing here, shows a dose-dependent GO1 cell cycle arrest. And interestingly, that happens also when TMEM97 and PGRMC1 are not present. So this might, we can conclude here that the effect of ceramycin does not depend on the protein status of TMEM97 and PGRMC1. Now, in an effort to see if and how ceramycin affects these proteins, we studied cells treated with ceramycin after 48 hours, and we see no impact, no significant alterations on the protein levels TMEM97 PGRMC1, a conclusion that emphasizes the hypothesis that ceramycin may act independently of the presence of sigma-2 receptors. To conclude, the silencing of TMEM97 or PGRMC1 or both has no impact on the proliferation and the cell cycle of PDAC cells. PGRMC1, but not TMEM, may affect the aggressiveness of PDAC based on a clonogenic assay. And another important thing is that ceramycin seems that it's not affected by the presence of these receptors, as a thing that supports the theory that some sigma-2 ligands are not influenced by the presence of this receptor, even if they are characterized as sigma-2 ligands. So, to clarify more this hypothesis, future experiments are planned in our lab, both in vitro and in vivo, also to see the role of these receptors and also to see how ceramycin acts, the mechanism of action of ceramycin, and its correlation between sigma-2 ligands, sigma-2 receptors, and the whole chemotherapeutic outcome in PDAC development. This is some bibliography. This research is supported by HFRI and DECA of University of Thessaly PhD fellowships. I want to thank my team that work on that project, and of course, thank you all.
Thank you very much, Mrs. Koussougianni. We now move to the final presentation for this session from Dr. Haris Mihailoudis from the School of Medicine of the European University Cyprus with the presentation topic on the role of eosinophil mitochondria function in severe eosinophilic asthma.
Okay, good morning. I'd like to thank the organizing committee for allowing me to present this work today. So asthma is a chronic inflammatory lung disease that involves extensive structural changes in the airway wall, leading to a narrowing of the airway lumen and therefore airflow obstruction. So asthmatic airways also show hyperresponsiveness to constrictor agonists, which can be induced by inhaled allergens or pollutants, leading to bronchoconstriction and asthma attacks, which further reduce the lumen. Therefore, patients with asthma are treated with corticosteroids, which reduce inflammation, and bronchodilators to protect from bronchoconstriction. However, 5 to 10% of patients with asthma suffer from severe asthma, where the symptoms persist despite the patients taking high doses of inhaled and oral corticosteroids, as well as bronchodilators. And these patients show a lower lung function and have more frequent attacks, and also side effects because of the high doses of oral corticosteroids they take. Therefore, they have increased mortality, lower quality of life, and a high cost to the national health system. Therefore, more effective treatments are required. A stumbling block in developing new therapies for severe asthma is the heterogeneity of the disease in terms of its causative factors, the genetic predisposition, as well as the underlying molecular and immune mechanisms. So a precision medicine approach is required in order to classify patients according to their cellular and molecular mechanisms. And this kind of approach has yielded biologic therapies that are currently used for severe asthma, such as the anti-IL-5 monoclonal antibodies. So in asthma, we have damage of the airway epithelium from inhaled irritants like allergens, pollutants, and smoke that trigger an abnormal immune response that consequently drives the remodeling of the airway wall and the bronchoconstriction, therefore driving the pathology. So there are three well-defined phenotypes of severe asthma according to the immune response they entail. The allergic and non-allergic eosinophilic asthma, which involve a Th2 type immune response and pronounced eosinophilia, as well as the neutrophilic asthma, which entails a Th1 and Th17 type response and neutrophilia. So in this study, we focused on severe eosinophilic asthma. So in severe eosinophilic asthma, or CEA, as I'm going to abbreviate it in this presentation, we have increased numbers of eosinophils in the lungs due to increased movement from the blood in response to chemoattractants, as well as due to increased survival and activation by Th2 type cytokines like interleukin-5. And eosinophils drive severe asthma pathology by promoting epithelial damage, remodeling, inflammation, and bronchoconstriction through the release of lipids and other types of inflammatory mediators. So in order to identify new treatments for severe eosinophilic asthma, we need to understand the mechanisms underlying the abnormal eosinophil function in this disease. So SCA patients that are not well controlled with standard treatments are prescribed biologics, such as mepolizumab, which is a monoclonal anti-IL-5 antibody that neutralizes IL-5 and therefore disrupts IL-5 signaling and survival of eosinophils. And studies have shown about 80% reduction in blood eosinophil counts and about 50% reduction in the exacerbation rates annually, which means that some patients still experience exacerbations after treatment, and this could be due to the persisting eosinophils. So another important aim is to understand the molecular phenotype of these persisting eosinophils following the treatment. So cellular metabolism is an important determinant of immune responses. This is the glucose oxidation pathway with glycolysis in the cytoplasm, producing acetyl coenzyme A that is then metabolized in the TCA or Krebs cycle to produce electrons that are then transferred across the electron transport chain to oxygen, driving the production of energy in the form of ATP. Mitochondria also regulate the intrinsic apoptotic pathway and therefore the survival of immune cells. And also glycolytic intermediates are used as nucleotide and fatty acid synthesis precursors. Therefore, immune cell activation and survival is often accompanied by reprogramming of glycolysis and OX-phos. So in this study, we hypothesized that eosinophils from patients with severe eosinophilic asthma have dysregulated glycolysis and OX-phos, which may drive their abnormal survival. So we determine these metabolic parameters in healthy subjects, patients with mild, moderate asthma, SCA patients on standard treatment, and patients on mepolizumab treatment. We also investigated the role of IL-5 in driving these metabolic changes and whether these metabolic reprogramming may promote the survival of eosinophils. So Subjects from the above groups I just mentioned were recruited at the Royal Brompton Hospital, London, and eosinophils were isolated by Perkel centrifugation and negative selection by magnetic labeling. So firstly, we measured OXPHOS and glycolysis activity using a Seahorse XF analyzer, which permits the sequential injection of OXPHOS inhibitors to treat the cells, and at the same time can measure oxygen consumption rates in the extracellular medium, allowing the calculation of basal, ATP-linked, and maximal oxidative phosphorylation. At the same time, it can measure extracellular acidification rates to calculate glycolytic activity. So using this method, we've shown that the SEA eosinophils, shown here with purple, have significantly higher rates of OXPHOS compared to the patients treated with mepolizumab, as well as mild, moderate asthmatics and healthy volunteers. And that was the same across all three parameters of OXPHOS. At the same time, SEA eosinophils also showed a higher glycolytic activity compared to the other three study groups. Therefore, the eosinophils of severe eosinophilic asthmatics have a metabolic reprogramming that involves higher glycolysis and OXPHOS, which is not seen in patients that were treated with mepolizumab. So based on this mepolizumab data, we then went on to see the effect of IL-5 on this metabolic reprogramming. And 10 nanograms per mil of IL-5 for 4 hours increased both OXPHOS and glycolysis in healthy eosinophils shown in blue and SEA eosinophils shown in purple. So we show here that IL-5 may be driving this metabolic reprogramming in severe asthma. We then went on to look at the effect of IL-5 on the survival of eosinophils using Annexin-5 propidium iodide staining. On the left-hand side here, we can see that at baseline, there's no significant difference between the survival of eosinophils between the two groups. But on the right-hand side here, IL-5 increases the survival of both healthy and SEA eosinophils. In order to try and link the metabolic reprogramming with the survival of eosinophils, we treated healthy and SEA eosinophils with a glycolytic inhibitor 2-deoxy-D-glucose and the OXPHOS inhibitor rotenone. So both inhibitors reduce the IL-5 dependent survival of healthy eosinophils. However, the same metabolic inhibitors had no effect on the SEA eosinophils, and this resistance may be because of the heightened glycolysis and OXPHOS that we observed due to the metabolic reprogramming. So to conclude, we have shown that eosinophils from severe eosinophilic asthma show metabolic reprogramming that entails increased OXPHOS and glycolytic activity, which may be driven by IL-5, which is also supported by our data from mepolizumab patients. We also showed that this reprogramming may be associated with the increased survival of eosinophils. Therefore, these initial findings will be continued, and there will be further studies involving transcriptomics and metabolomics in order to specifically see the mechanisms driving the reprogramming and maybe identify biomarkers for predicting or diagnosing this phenotype. So just some acknowledgements. I would like to thank my collaborators at Imperial College London, specifically Dr. Bravzar and his group at the NHLI and the Royal Brompton Hospital. And this work was funded by an NHLI Foundation scholarship, which covered our PhD student, Giannis Korateng, who carried out most of this experimental work. Thank you very much for your attention.
Thank you very much, Dr. Mihailoudis.
For our next session, the satellite session by Cambridge Medical Academy, featuring a series of 12-minute lectures followed by 2 minutes question and answers for each presentation, we're pleased to invite our session chairs, Dr. Konstantinos Stylianou and Dr. Stefanos Christodoulidis, to the stage.
Good morning, everyone. I want to welcome you to our next session for today with the theme Satellite Session by Cambridge Medical Academy, One Health Personalized Medicine. I want to welcome to the podium our first speaker for today, Mr. Takis Skotis. Mr. Takis Skotis graduated from the University of Minnesota, Twin Cities, with the bachelor's degrees in Health and Economics and a Master's of Business Administration, MBA, in Healthcare Administration Management. With over 40 years of experience in the healthcare industry, he specializes in transforming healthcare organizations through information and communications technology, focusing on strategic management, business intelligence, and healthcare KPIs. And today he's going to talk about innovation and entrepreneurship in One Health Personalized Medicine.
Thank you very much for the introduction, and I would like to welcome you to this session, Personalized Medicine, and also I would like to thank the organizing committee and especially Mr. Yannis Patrikios, who invited us. And also I would like to, before I start, I would like to ask you, how many of you attended Professor Adonarakis' presentation last night? Okay, great. So I believe that what you heard Professor Adonarakis mention yesterday and what we are going to present to you today, it's a continuation of this great talk that he gave. I'm not going to attempt to analyze his 4 kilos chromosome 21 book, but what I'm going to do is concentrate in 2 areas that he mentioned. Number 1, he said personalized and precision medicine. He didn't like those words. He didn't think that expressed exactly what those 2 words mean. So for all practical purposes, let's stick with personalized and precision medicine, and let's see where technology is going to drive us. Here, let me tell you a personal story of another terminology that we use. It's called telemedicine. In 1995, we were invited to participate at the Royal Brompton Hospital on a project to study congenital heart disease remotely, utilizing telemedicine. And everybody was saying, why the term telemedicine? Well, telemedicine gave us the opportunity to study medical cases, not only like by that time we used to use as a telephone, but to utilize images. The term telemedicine today, it's called e-health. So we hope that what you hear today, personalized precision, is going to be transformed in the coming years into something new. But I'm going to stick with what Professor Adonarakis closed his presentation last night with very important quotation from Sophocles, the tragic poet, from 496 to 406 BC. In Greek, τι να κάνετε τη γνώση εάν δεν σου χρησιμοποιεί σε τίποτα? In English, what to do with knowledge if it's no use? So, today we're going to present to you our knowledge, how it's going to be put into use. And I'm going to start with a definition of what is personalized medicine and how we define personalized precision medicine. Personalized medicine tailors healthcare to individual patient characteristics to improve treatment outcomes and reduce adverse events. This is what we think is our base of personalized or precision medicine. So what is the core idea of this? Is to customize health guidance, diagnosis, and treatment to each person's unique genetic, clinical, and lifestyle profile. And we have a vision. Imagine health guidance selected just for you, minimizing side effects and maximize outcomes. Imagine receiving precise diagnosis based on your unique situation and having this ability to predict and prevent illnesses before they develop. We believe that our approach is unique and it does transform the healthcare systems. Personalized medicine, it's not just about prescribing the best drugs. Imagine a system where diagnosis is not only more accurate, but tailored specifically to you. Picture predicting the likelihood of developing a condition before it even arises. Having the tools to prevent it from progressing. So our approach is intersectional. And what do we mean intersectional? We interact with 4 important areas that we believe are crucial to the personalized precision medicine. Number 1, the genetic profile, DNA. Number 2, phytotherapy, herbs. Number 3, artificial intelligence. Number 4, your social and behavioral profile. So this is our holistic perspective to considering individual and population level data to understand health and illness symptoms. What is our approach to this initiative? The concept of personalized medicine includes selective genotype-based prescription of drugs to individuals for whom the drug should be safe and effective. Traditional medical treatments have been designed as a one-size-fits-all approach. But while these treatments can be effective for some patients, they may not be for others. Precision medicine takes into account individual differences in genes, environments, and lifestyles. In this way, doctors can select treatments that are most likely to help based on a more complete picture and understanding of their disease or ailment. What is the innovation and what is the business model, the entrepreneurship on this initiative? Personalized medicine uses molecular insights to create targeted treatments, linking natural compounds to gene targets. This approach advances drug discovery and offers innovative therapies for today's health challenges. So what is the foundational concept? By having a complete understanding of the molecular effects of chemical compounds, facilitates strategic selection of candidates for advancement in modern drug discovery. And what is our future direction? By examining those gene targets for herbs ingredients and link herb ingredients to various modern diseases, we believe that hasn't been considered before, and this is our aim. So, our One Health journey unites expertise to make individual and population health more proactive, predictive, precise, and personalized. The most important thing is what Sophocles was saying, the use. This is how we are going to apply it, by empowering individuals and communities as partners in their own wellness, by training the next generation of data-fluent and multidisciplinary health professionals. We call it the new generation 21st century general practitioners. This is how we started. In April 2024, with our first event at the University of Cambridge. The University of Cambridge has 125 Nobel Prize winners. One of those 125 is Francis Crick, and his discovery was the structure of the DNA. It wasn't by accident that we selected the same building that Francis Crick was teaching, the King's College, because we wanted to give a message that what we're attempting to do is something that DNA is the strong base for it. So the next events, November 27th, we're going to be in China, in Banan, 29th in Xi'an. Why Xi'an? Xi'an is known for the terracotta warriors. Xi'an is the second most important city in China after Beijing. And the saying goes that close to 35 years ago, a Greek sculpture worked together with the Chinese in order to produce the terracotta warriors. For us, it's very symbolical. And of course, in March, we are going to be again in the eastern part of China called Ningbo, and then we're coming to Nicosia, and we are going to attempt, for the first time, to bring the Balkan herbal experience into the map. So, 2 days ago, it was the opening of those conferences in China, but also for the rest of the world. As you can see, it's called One Health, One Road. Why did we choose the personalized medicine to call it One Health, One Road? We started with the term One Belt, One Road. Belt refers to the proposed overland routes for road and rail transportation through landlocked Central Asia along the famed historical trade routes of the Western regions. In other words, it starts from China and it ends in Rotterdam. And the road is short for the maritime Silk Road. We felt that One Belt, One Road was an excellent vehicle for us in order to transform our initiative from east to west. But in 2017, I visited a small place in China, a hospital that was called Changzhou First People's Hospital. And as I entered the hospital, on the left side, it was a wall painting, the one that you see in the middle. And what is there? It's a Greek physician examining a child. On the bottom left, traditional Chinese doctors. On the bottom right, you see the Western doctors. And in the middle, you see the Hippocrates Oath. For me, when I saw this, the whole medicine history went through my mind. That's why I call it One Health, One Road. So, One Health, One Road's novel approach promotes a universal model of healthcare delivery through innovative means of training, experience sharing, and technology transfer, aiming to unite the practices of traditional Chinese medicine, ancient Greek medical practices, and contemporary Western medicine. We know that this journey is long, but we're just starting. Thank you.
Thank you so much. That was an amazing presentation, and I agree with Mr. Takis that precision medicine is the future, and this is the way to go. We have only time for one question only. Do we have a microphone that we can pass?
Thank you very much. As you walk up there, I was very impressed last night by the major presentation that we had, but I'm not quite happy that I agree with Sophocles, where you said, what's the knowledge if it has no use? I actually believe any knowledge has some use. So he's actually wrong in the second part of the equation. So even if you develop knowledge today, it may be useful sometime, somewhere. So every knowledge has a use. But in general, the precision medicine is right, but it's also wrong. If I have a sore throat and I have a fever, I go to see my GP, give me some penicillin, within a week I'm better. He doesn't care about my DNA, about my environment, the drug works, and I feel great. And also, if you look at vaccination, we recently had a vaccine called COVID, that has saved 20 million people, if you look at the analysis. None of us know anything about their DNA, their environment. They could be in Africa, they could be in China. So precision medicine, I think, is much more important for difficult diseases. And I will actually say something when it comes to cancer. And I congratulate you on what you have created. I have some concerns with your close contact with the Chinese, because of course they have one China themselves. And it may not go down very well with the new American president.
Thank you for your question. Very valuable. Yes, I do agree that knowledge, any knowledge, should be put into use. But I do believe very strongly that we should put knowledge into practical use. So I have been in healthcare business for more than 45 years, and I have seen a lot of research being done, a lot of money being spent by the European Union, and nothing happens. So my purpose is to take some good ideas, good knowledge, and turn it into practical use for the citizen to be assisted and to be making their life better. So when we talk about precision and personalized medicine, yes, there are some cases that maybe doesn't apply. But consider cases where, like third age, how precision medicine can help in order to make the third age citizens a little bit better quality life. So, as I said again, as I close my talk, it's the beginning, it's the start. But we believe that we have a good foot on the start. Any other questions?
Thank you so much.
Thank you very much. So good morning, everyone. So I would like to introduce our next presenter, so Dr. Dimitris Tsikas. Dimitris Tsikas is a remote sensing and surveying engineer. He received his degree from the National Technical University of Athens in 2010, where he also received his PhD in hyperspectral remote sensing in 2016. Dimitris joined Claudio as the Chief Technological Officer of the group. Dimitris is also the founder of the GEO University, an online learning platform on GIS and Earth observation. So the title of his lecture today is One Health Herb Registry System, a New Frontier in Herbal Medicine. Dr. Sigas, the floor is yours. We cannot hear you.
Yes, can you hear me?
Yeah, we can hear you now. Thank you.
Second. Can you hear me now?
Yes.
Yeah. Okay. So first of all, thank you very much for the invite. It's an honor to present in this conference. So today I'm going to present you our initiative about the One Health herb registry system. So in terms of the way that we are thinking about the herbs on how they're revolutionizing herb medicine, we introduce a cutting-edge herb registry system to bridge the ancient wisdom together with modern science. At our core of our design is the standardization. So we want to create a uniform platform, a database for herb profiles from botanical details to medical properties, and combine this with individual clinical details. Then, as part of also this initiative is the intelligent data processing module, as we say it, which utilizes advanced large language models in order to parse and extract patient information from different scientific studies and sources. And of course, this will really enhance the research capabilities by taking into account all these different varieties of sources. Yeah. So in terms of, in order to be able to do this, we need the database architecture. So we have already performed structured data storage. So we have organized the database in a way that it is we have introduced different kind of concepts and properties within this system, and connected all the different types of connections between them. A very big importance was given to the dynamic synonyms. So because, as probably most of you already know, herbs do have different namings and very often get confused with each other. So a very elaborate and detailed cross-reference work has been done in order to ensure that the naming and the connection between the names is done properly. Within this platform, I would say we already included different types of information like active substances, including the chemical types and compounds within each herb in order to facilitate the research that is going to be needed. Also, we have included different geographical insights in order to be able to cross-correlate the herb properties together with some environmental impacts and the potential impact also of climate change. And of course, we are building some community engagement functionality in order to be able for the users of this platform to be able to interact with each other and exchange information. So in order to be able to facilitate this process, we have really focused on the standardization, so to have a uniform botanical nomenclature. So when each scientist refers to one specific name to ensure that everybody understands exactly the same thing. We have also introduced different kind of quality control mechanisms in order to maintain the quality of the input data within the system. And we have also defined a herbal lexicon in order to facilitate this process. On top of that, we have been this standardization process supports supports the healthcare decision. So to assist, the whole scope is to assist the healthcare professionals in making informed decisions when providing standardized and comprehensive herbal profiles in order to ensure the data integration. So the whole point of this data is to be able to be integrated with other systems and AI algorithms in order to be able to extract information that really wasn't known before. And as part of this process is to also facilitate the educational outreach. So having this type of platform, we can also provide, we can also facilitate the educational, let's say, aspects of physicians. Now, let's say the herbal medical products are something that is not so much, let's say, integrated into the medical system in the EU. We have been working closely to follow the directives that are in place in order to ensure compliance and be able to help and facilitate the researchers in the process of the monographs that will help the future medication. Now, from one part of the AI part of the system is the intelligent data extraction module. So this focuses on a process that reads different kind of scientific materials and understands it. And based on the structure of the platform, it really maps the specific interests that are exposed within its scientific paper and maps them within the structure of the database in order to be able to automatically or semi-automatically extract the knowledge from its purpose. This is really important because thousands of papers are published every year on this vertical, let's say. So a process that really not just catalogs but extract all the structured, meaningful information from this is quite essential. So, so first of all, this is a scalable process. So by design, we can apply it to hundreds or thousands of different documents simultaneously. It can dynamically enrich all these documents with specific nomenclature and the specific things that we want to have. And import all these aspects with inside the platform. Now, as we see the herb registry, we see it as a tool for physicians, so to empower GPs actually to introduce the GPs to the herb registry system for an extensive reference in herbal medicine, helping the decision support. Of course, always the physician is the expert and they know how to decide, but as a tool to help them and facilitate this process by providing them accurate references and suggestions on potential treatments. It's something that it's of use. It is very easy to access, and we have been working also with clinical integration, and we continuously update the process. Now, another part that it's really important, as Mr. Takis said before, is the personalized medicine. With the herb registry, we can have individual profiles, target therapies, and predictive analytics. So we can really track the outcome of the treatment that is needed. And this is something that really empowers also the patient in order to be able to better understand the treatment and what's happening. And something more on this, we have been working also in the Greek, let's say, use case. So how to adapt, let's say, the traditional Chinese medicine to the Western medical system. So we have started with a data collection process, an initiative that we will examine 5,000 people from ages from 5 to to 18 as a first step. We're going to sample DNA with saliva samples and gather all the medical history and both the individual and the family history, and also measure cardiovascular measurements in the field for each person that will be examined. And the scope of this is to detect the murmur in the early stages and combine them with the DNA and clinical measurements. And having all these, let's say, profiles together with the genomes and all the active chemical substances from the herbs, we can help research in order to provide some more elaborate treatments in the future, of course. Thank you very much.
Thank you very much, Dr. Sikas, for the excellent presentation. I think we have time for only one question.
Yes.
I have actually one question. Thank you so much, Mr. Sikas. I'm very interested in this topic as an integrative oncologist myself, and there is already some herbal or in the market databases, for example, about herbs from Memorial Sloan Cancer Center, which we have been using for a couple of years. So I'm wondering, what is the difference between your platform and how would that change with the already existing ones?
Yes, so if I actually did well because it had a small gap in the connection. Provide a base to get the personalized treatment. So let's say our focus is more on the health side of things. I don't know if this answers your question. Apologies because I didn't hear you also very well.
Thank you so much. I want to welcome on the podium our next speaker, Mr. Lars Manter. Mr. Lars, he's a dedicated champion for health literacy in Europe. He holds an MA in rhetoric and natural science from Copenhagen University. As part of his professional work in Scandinavia and Europe, his skills of combining communication and science has led to knowledge sharing and joint platforms to promote self-care, empowerment, and citizen action, including corporate social responsibility, and has been seen core of daily activities across sectors and borders for 20 years in Danish, Nordic, and European initiatives and projects. He will talk to us about personalized medicine, the future of health and dignity. Thank you so much.
Well, thank you for having me. It's a pleasure to be here in Cyprus. I am, in this particular context, not just a traveler in geography, but also a time traveler, as you'll see in a few minutes, or within 11 and 4 seconds or so. But personalized medicine, the presentation yesterday sort of stole one of the core elements of my presentation here, but to sort of just to add to that reflection about the differences that we have. How many of you in this room identify as a man? By raising of your hands. How many identify as a woman? Any that are brave enough to identify as something else? Okay, so basically though, the pointer works slowly, but it works. Who are you? You have different identities. In addition though, who really likes a good romance when you go to the movies? Showing of hands, who likes a good romance? Okay, some. Some that would maybe prefer a sci-fi movie? None? That's amazing, considering the room. But maybe more an action movie? No? Some? Yeah? So, okay, cool. You have different tastes, too. What about if you think about if you were to go out to go shopping for clothes, if they only had the size large, would you be satisfied? Or would that be a problem? Showing of your hands. Do you? Aha. So you have different needs. And if all you actually had as an opportunity for your future was to become a plumber, would that be a good sort of career choice for you? Raise your hands. None. Not that surprising given the room. But so, you have different priorities in terms of your future. Essentially, of course, on a microbiological level too, you are unique. But not just sort of DNA-wise, also mentally, physiologically as well. So given that uniqueness in terms of your identity, in terms of your taste, your needs, your priorities, why then do we accept generalized medicine? It doesn't really make sense. So what we've done then also based on that idea, working in the Nordics, is to work with a concept where we also time travel a little bit. The current generalized medicine is not necessarily per se fit for purpose, considering the needs that we have, the priorities that we have in the future, and of course the burden that the current system actually places on our planet and on our system. But what would a future look like? So imagine traveling into the future, 20, 30 years. How would you like the health system to look like? What were the kind of solutions that you would prefer to see? And if you imagine those kinds of elements that fit your taste, that fit your priorities, that fit your needs, how can you then start building systems that would support that future? Because the reality that we're in today is the sort of the sum of the choices that we made 10 years ago, 20 years ago, 30 years ago. The future that we'll have in 30 years are the results of the choices that we make today, tomorrow, and maybe the day after. So be very conscious of the future that we're looking for when we make choices. In the Nordics then, that leads us to the 5-5 aspiration. No longer should we use 10% of our GDP for curative services. It doesn't actually lead too much in terms of well-being. It doesn't actually lead to a good use of resources. And it doesn't necessarily lead to an overall well-being for our patients. Instead, we should aspire to use only 5% on curative services and 5% on preventative services instead. It's a profound shift that is, of course, an aspiration in this sense because none of the countries on the earth are using this. But of course, this is the way forward because the point is not for us to be better at fixing problems. The point must be to prevent problems from occurring in the first place. That work then led us to what we call the sustainable health model. It's a balance of a system and a citizen, an empowered citizen that is on par with the system. This is not about a system doing something for people. It's not about a system doing something to people. It's doing something with people. And it's about people, empowered, health literate people, doing something that also enables a data flow between the two opposite poles, if you will, that allows a data model in the middle that sort of supports the research that we also need for it all to happen. It is not an either or where the data lies. It's a common good for us all. So does that lead to perfection, dignity in every sense? Maybe not. But the aspiration is that we can try in every sense of the word to also have a personalized approach, a precision approach, where we try to work with dignity. We also need to work with trust And as opposed to the slide just before, this is a little bit more data heavy. But we often talk about trust as something that we really want and need in health, in our systems, in our societal systems. And we talk often about how it's really so sad that trust gets destroyed by bad decisions or by bad frameworks. But let's remember that trust is not just something that you can destroy, it's also something that you can build. It requires that you actually, though, think about both the phases of when you collaborate with other people, how you do it. In this particular context, this is, well, it's not stolen because I actually built it myself, but it's taken from a case of the Danish life science cluster, where we think about how do we collaborate, how do we put people together in the assembly phase, how do we then build a partnership, the build-up phase, how do we do the trust-building phase, the short-term and long-term resource, and how can we measure on each of these phases so that it actually makes sense and that we're held to account that we're actually doing what we're promising to do, so that we build trust. And if you find this sort of tricky to understand, think about maybe Formula One racing. Some of the engineers are focusing only on engine capacity. They don't care about the driver, they don't care about the wheels, they don't care about the chassis per se. They care about the engine capacity. Because they know that unless they actually figure out how to do the engine capacity, it won't matter what kind of wheels you've got, what kind of chassis you've got, and whether you hired the right driver. But you have to figure out how to build engine capacity to be able to deliver power to transition. That is what we're doing with this model. How do we work with relational capacity that allow us to have the power to change stuff? And for each of these steps, how can we measure whether we are on the right track? This is a more simplified version of the same, but allows you to, within 5 different domains, to assess your progress in a partnership so that you can actually assess whether you have the trust that would lead to transformation. Unless you have the trust that can lead to transformation, it won't happen. Trust, or change, as they say, only move at the speed of trust. In that, then, we should also be humble. One of the key elements to that is to be humble and to have knowledge sharing across professions. This is about involving designers. This is about involving psychologists. It's about involving urban planners. It's about involving professions other than our own. It's about integrating other approaches. Some of them that might be psychological of nature, some of them that might involve civil society, some of them that are beyond, in this case, the medical field, but involves different elements. Geographies, how do they do it elsewhere? Genomes, how do we do it across the different needs of the people? And of course, the cultural approaches. This is cutting-edge technology of 1920. People were really fascinated about it in 1920s. It had the carrying capacity of 1. It could fly, sort of. It wasn't very safe and it didn't fly very far, but it could fly. Cutting-edge technology of 2020 looks like this. A bit more confusing, but it can fly much further, much farther, much safer, and for many more people. It requires a skilled pilot, and it requires a hell of a lot of data to fire that data dashboard. The current system that we're in still relies on us to actually build that data dashboard so that we can fly the technology of tomorrow. It involves a lot of data. It also involves a future care where we are willing, and that's the dignity part as well, willing to listen to the people. What are their tastes? What are their priorities? What are their needs? what is it that we can, as a medical community, motivate and engage them so that they actually take our advice, so that they sometimes take the medicine, so that they, over time, actually work on their own health. We will often only get a very small window of opportunity, the talk, the motivation, the information, to motivate them to do all the real work. We have maybe an hour every year to talk to them. They are left alone on their own devices the rest of the time. So unless we listen, and listen carefully, and give them the right time of motivation, it doesn't actually matter much. It's a future care that integrates technology, integrates the perspectives, integrates other types of profession, and it's one that adapts very much to those different needs, and adapts, of course, to emerging technologies of how smart homes might be, how we deliver health not at a hospital, but at home, or on the go, for that matter, because you are unique. Thank you very much.
Thank you, Mr. Hunter. Technology is becoming a big part of our lives, and we have to get on board with that, whether we like it or not. So we have time for only one question. I see only one hand, so please go ahead.
Thank you. I'm a physician. We all believe that prevention is better than cure. Whatever taste I have and what driving test I do, so prevention is better than cure. And that basically, these boxes that you are saying, whether it's precision or whatever it is. But we cannot always achieve prevention. You need to spend a lot of money to prevent the medicine. Unfortunately, some illnesses appear out of the blue, undetected and dramatic, and they need real treatment. Your comment of dignity in your title, I actually find slightly insulting. Trust and dignity. I would have thought physicians over the last few thousand years have been treating their patients with dignity and trust. In other words, it's nothing new to have dignity and trust.
The current development of drugs are one that has predominantly used white men as the guinea pigs to test the drugs. A lot of women, a lot of non-Westerners take offense to that. It is our dignity, but it's not their dignity. So while, for instance, there's a lot of qualities to a generalized approach that have been hugely effective as opposed to the previous method of, I don't know, middle age, the Middle Ages, the Dark Ages, trial and error and approach, and the modern medicine has done that far better. But it's not been based on individual approach, it's been on a generalized approach. And it doesn't necessarily take very much into account what the individual needs. The sad thing about it, though, is that the way that we use GPs in our modern system is not a very good way for the GPs either. Their key role as a GP and as a beacon of knowledge is not to have 5-10-minute consultations with their patients. It could be, it should be, as a motivator. It should be as a beacon in their community, and not someone that has to hide behind a desk because that's all there's time for. I would hope that the future GPs is one that actually is working in the community. It's a communicator. It's a visionary that actually drives that health, and not just someone that is more or less, and don't get me wrong, used as a machine, a cog in a huge machinery where we are just throwing more and more patient at that individual. That role is one that can be solved more or less by an AI. The role of a motivator, the role of a dedicated individual that can make a change that would allow a community to move from one sort of lifestyle to another, that requires a human being with dedication. And that is one where I see the future GP to do that instead, with dignity in the community. I hope that answers your question.
Thank you.
Thank you very much. So I would like to welcome our next presenter, Dr. Fan Chempong. He graduated from Hunan University of TCM, China, with a master's degree in acupuncture. He served as a consultant doctor and a manager of Chongqing TCM Hospital, also a professor of Chongqing University of TCM, China. Currently, he is the deputy director of the medical department of Chongqing TCM Hospital. He is the vice chairman of the acupuncture equipment committee of Chongqing Acupuncture and Maxi Bastion Society, standing committee member of Chongqing Maxi Bastion Society. So the title of his lecture today is Personalized Treatment in Traditional Chinese Medicine. So Dr. Chempong, the floor is yours. Can you hear us?
Can you hear us? Hello? Can you hear?
Yeah.
Yeah. So let's share my screen. Is it okay?
Yeah, we can hear you clearly.
Today's conference. I'm Fan from Chongqing Traditional Chinese Medicine Hospital. Today, the topic I'm bringing today is personalized medicine in TCM. I'm going to share my views from the following two parts. As Professor Takis said, he has explained what is personalized medicine. Personalized medicine refers to new treatment modalities based
Sorry
on
to interrupt you.
Sorry to interrupt you.
Can you share your screen with us?
Can you share your screen with us? Okay.
So on the lower button of your screen, there's a share button that you can share your presentation.
Is that okay?
We're still, yeah, now this is great, thank you. Yes. Can you maximize your screen too?
On different individual predisposition or lifestyle variability. The rise of personalized medicine means that the one-size-fits-all, as Professor Takis said, is being replaced by providing the right medication to the right patient at the right time. As is well known, personalized medicine has been increasingly valued in recent years. It can not only achieve more precise treatment, but also save medical resources, reduce unnecessary side effects, improve efficacy, and increase potency ratio. From the management of blood pressure for hypertension, controlling blood sugar for diabetes, to attend to targeted drugs for the treatment of tumors, personalized medicine has unconsciously existed around us. In fact, personalized medicine in TCM has been practiced and passed down for 1,000 years. You know, the holistic concept and the syndrome differentiation treatment are the two most important characteristics in traditional Chinese medicine. TCM holds that the human body is an organic whole. It also emphasizes that the harmony between human and the society environment, human and the nature. So we think every patient is unique, such as Professor Lars Munter just said. personal constitution may be impacted by many factors like gender, age, emotion, climate, work intensity, and lifestyle. Syndrome differentiation and treatment in TCM refers to comprehensive analysis of information collected by the 4 diagnostic methods to determine which syndrome type the patient belongs to, and then take different treatment based on this syndrome type. For this
Dr.
reason, treatment
Fan,
should be based.
sorry,
Yes.
do you mind following your slides and sharing them with us along your talk?
Yes. Okay. Thank you for reminding me. So, under the guidance of this principle, we can treat the same disease with different approaches, like insomnia, or treating different disease with the same approach. We just use one TCM pills to treat like uterine prolapse and rectal prolapse and so on. So let's move to the second part. Now I'll take the TCM treatment for insomnia as an example to elaborate how traditional Chinese medicine provides personalized treatment. There are many causes that lead to insomnia from the perspective of modern medicine. As it's shown from the table, we can see the life events and social factors like displacement due to traumatic events, traffic noise, owing money, and so on are the common causes. On the other hand, medical and psychiatric disorders like anxiety, depression, post-traumatic stress disorder, and so on are also the causes. And most methods for treating insomnia involve the use of sedatives like hypnotic, such as benzodiazepine, which is common use for insomnia. However, it can cause respiratory depression, and long-term use can result in tolerance. Triazolam can cause anterograde amnesia. Actually, hypnotic medications improve sleep only modestly. On the other hand, from the perspective of TCM, we think that causes of insomnia, including imbalance of yin and yang, lack of qi and blood, disharmony in the stomach, invasion of external pathogens, sometimes drinking too much coffee or tea, also the reason. We will conduct a comprehensive analysis based on the patient's medical history, like tongue image and health conditions. Usually, it can be classified into 5 types of syndromes. First, we have syndrome of phlegm, fire, disturbing heart. The causes including long-term consumption of spicy food, greasy food, or fried food.
Dr. Fan, I'm so sorry to interrupt you again, but we're not seeing your, we're not swapping your slides, so we can't really follow with the talk. So if you move your slides along with your talk, will be much helpful.
Wake up, toss and turn all night, erratic,
Dr. Fan,
Sometimes
you need to
okay.
stop sharing your screen for us.
Okay, stop.
Stop. Perfect, thank you. Can you start to reshare your screen? Yes. Can you move it up and down to see if it works this time?
Okay, what you need to do is to share the whole screen, please. Try to move the slides. Yeah, we cannot see that, so I think you need to share the whole screen.
Is that okay?
You need to share the slide view screen. Ah. Okay, you can proceed like that.
I'm shifting my slide. Can you see the movement?
No, we can't.
So I can't do this in the whole screen. So I conduct my speech.
Leave it like
just
that, leave it
this.
like that, and we can continue like that.
Okay. Yes, sorry. Okay. So let's look at the symptoms of syndrome of flame, fire, disturbing heart. It's including excited, difficult to sleep, easy to wake up, toss and turn all night, erratic, dry and bitter mouth, cough, chest tightness. A patient may have red tongue with yellow greasy coating, smooth or slippery pulse, maybe a little bit rapid. So for this syndrome, we use 黄连温胆 decoction. It composed of Coptis chineses, dried tangerine peel, Coreococcus, and so on. And the stimulation of certain acupoints is also recommended. Lifestyle education, including changing dietary structure. So next, we have syndrome of liver depression transforming to fire. We think the liver is responsible for regulating emotional activity and regulating chi flow. If the liver's function of regulating is imbalanced, chi flow becomes stagnant, and prolonged stagnation may turn into fire. But then, excessive fire will damage the yin energy, just like range fire that vaporizes water. The balance between yin and yang will be disrupted. The yang cannot enter yin at night, so they can't fall asleep. Symptoms including difficult sleep, frequent dreaming, and easy awaking, even stay up all night, accompanied with dizziness, head bloating, headache, red eye, and bitter mouth, chest distension, restlessness. They may have red tongue with yellow coating, taut pulse. So for this syndrome, we use 单支逍遥 pill. It composed of peony bark, white peony roots, and so on. and we can stimulate action points like 和太冲, and patients should adjusting one's mood. Let's move to the syndrome of deficiency of both heart and spleen. Traditional Chinese medicine believes that the spleen is responsible for absorbing the essence of food and forming qi and blood, while the heart is responsible for providing the power to run qi and blood. Normally, the heart needs to be nourished by qi and blood, and we believe the heart is the lord of the mind. Insufficient endowment, overwork, overthinking, diary deficiency, chronic blood loss. Those situations probably lead to spleen deficiency and obstruct the function of converting ingested food into qi and blood. So the heart loses the nourishment, then mind will lose control. The symptoms including difficult sleep, frequent dreaming, palpitation, shortness of breath, pale complexion, fatigue, abdominal distension, loose stools, and so on. Patient may have pale red tongue, deep thready pulse. So we use squeepy pills to treat this. Acupoint stimulation is also recommended, such as 足三里, 内观, lifestyle education including having nutritional diet. So next we have syndrome of qi deficiency of heart and gallbladder. Causes including insufficient endowment or being startled by horrible visuals or sounds. So symptoms like palpitation, frequent dreaming, easily awakened from dreams, toss and turn sleepless all night, like to be alone, fatigue, hesitation when making decisions. They may have pale red tongue with thin white coating, thready and taut pulse. So we just use 酸枣仁 decoction to treat this pattern. It composed of wild jujube, Poriococcus, licorice, and so on. Acupoints like 百会, 神门, 内观 is recommended, and we will suggest patient to listen comfortable music, be with family members or friends. Last, we have syndrome of heart-kidney imbalance. In TCM theory, we believe that the heart is located in the superior position, belongs to fire of the 5 elements, while kidney is located in inferior position, belongs to water. These two viscerals are mutually opposite and constraining. If this balance is disrupted by any factor, it will lead to excessive heat in the heart, and the mind will out of control as well. So the symptoms including difficult to sleep, frequent dreaming.
Dr. Chenpang, you need to conclude because we are running out of time, please.
Okay, I'll be quick. So for this syndrome, we use 胶肽 pills. So that's this is just some example about treating insomnia. Actually, we have personalized diagnosis and treatment plans for every disease. There are even dozens of treatment approaches for certain disease. Okay, that's all today's presentation. Thank you very much for your attention.
So thank you very much for the interesting presentation. Unfortunately, we have no time for questions, but thank you so much. Thank you.
Thank you. Thank you.
Our following session is the new frontiers, genetics, epigenetics, and molecular medicine. We now call upon the chairs, Dr. Apostolos Zaravanis and Dr. Evi Farazi, to lead this session.
Okay, let's continue to the next session. It's a pleasure to introduce Dr. Yorgos Abidianakis. He is an expert in modeling micrometabolite host interactions leading to dysplasia and tumorigenesis using genetics and intestinal histopathology and physiology assays. Our team, their team studies bacteria and carcinogenesis in Drosophila, mice and humans, and exploits the potential of in vitro systems for preclinical trials. He has been trained for 10 years at Harvard Medical School in biomedical research, 6 years as a postdoctoral fellow, and 4 years as a Harvard instructor in medicine in the field of human infectious diseases and carcinogenesis, practicing research at the Massachusetts General Hospital and the Shriners Hospitals for Children in Boston, in the United States. He will talk to us about young enterocyte progenitor clustering and notch locus epigenetic instability as biomarkers of Drosophila aging. Thank you very much.
Thank you for introducing me, and many thanks to Ioannis Patrikios, Dr. Ioannis Patrikios, inviting me for one more year in this very nice conference. I will talk about stem cells and how they are leading their way towards tumorigenesis. Our team forms the Drosophila Biomedical Research Unit. We're doing a lot of research using Drosophila. We also run the Cyprus Intestinal Health Study, which aims towards colon cancer prevention. We try to get clues from basic research. Basic research is indispensable. It's the basis of all knowledge. And then we move on to applied stuff. The question I'm going to ask and try to answer today is when and why stem cells malfunction upon aging. We know that stem cells malfunction upon aging. Sometimes they stop to divide, but other times they overproliferate and they give rise to cancers. So when and why stem cells malfunction is something we don't know, even at a very basal level. So the common assumption is that there is cellular signaling that goes wrong, or the homeostasis of tissue goes wrong, and that's how things go bad for the cells, the tissues, and organs. When you compare young and old stem cells, you see a lot of differences depending on the tissue, but we don't know when this starts and why this starts. Here I'm going to show you some data regarding a different idea that stem cells are already flawed to begin with. We notice some signaling instability, not signaling instability, in young stem cells, ones that are supposed to be very healthy. And this leads to stem cells of mixed identity, and these in turn aggregate and they form dysplasias, and dysplasias are predisposing for bona fide tumor formation, for example, from mutation of tumor suppressor genes. So we propose, I'll have the proposition in the beginning, that stem cells are inherently flawed and that their aggregates can be a biomarker of intestinal health and overall aging, I would dare say. So we use Drosophila, and this is to show you that they are analogous structures. There is the pancreas, insulin-producing cells in the brain, actually. There is muscle, there is the dorsal vessel. There is, does this function as a laser pointer? No. So, yeah, pretty much all the basic organs of humans: kidney, liver, lungs, and the digestive system, of course. You see here the analogies between the Drosophila and the mammalian gastrointestinal tract. And the stem cells, ISCs, if you learn one acronym, that would be it, ISCs, intestinal stem cells. You see that intestinal stem cells are the basis of producing the enterocytes and the enteroendocrine cells. And these types of cells exist also in humans. Drosophila is an insect. The insect belongs to arthropods. Arthropods are the simplest organisms that have intestinal stem cells. So studying them in Drosophila, we combine simplicity with functional analogy with that of humans. Humans would be in the chordates at the very bottom of this tree. A stem cell, intestinal stem cell, gives two progeny. Whenever it divides, it gives two cells. One cell divides, gives two cells. Most of the time, it produces itself plus an enteroblast, EB. Other times, it produces two stem cells, two EBs, or one stem cell and one pre-E, that is the pre-enteroendocrine cell. And this is what everybody states in many different organisms. Pretty much stem cells divide either symmetrically and they give two similar cells, two stem cells, for example, or two different cells. Most of the times, the stem cell reproduces itself. If it doesn't, then it's lost. And this is the canonical progeny, but what we find is that a stem cell can give rise to cells of mixed identity, which tend to cluster. And although this has been noticed in all the flies and all the organisms in general, this is something that we notice in very young ones. And we measured that with 3 different markers. Delta here is a stem cell marker, delta GFP, delta LAC-Z, and ISC GFP, that is intestinal stem cell GFP. You can see the tall bars are the ones of the old flies. There is roughly an analogy between the days of flies and the days of humans, roughly. So in old flies, in relatively old flies, we see a lot of those, but you may appreciate that even in the first bars, that's in 4 days, that's pretty young flies, very young flies. They have a significant number of these clusters, that is abnormal stem cells clustering. And we then asked what exactly is wrong with these cells that they cluster. Clustering is already one problem, but we also noticed that they have more copies of DNA, sometimes up to, you can appreciate in the graph here on your left, that the ploidy goes up, the copies of DNA in the nucleus, extremely high, which is not typical of any stem cell. Plus, they have some increased admixture with markers of more differentiated cells, the enteroblasts, to a great percentage of them. That's the small graph at the bottom. So more DNA copies, other cells' identity, and clustering are the basic characteristics of this abnormal progeny of the stem cells. Where does this lead to? Overall, to more mitosis. Sometimes, in essence, drives stem cells to die or be hyporesponsive, but in the gut, it's the opposite is happening. We have overactive stem cells. So mitosis goes up, You can see the tall bars over there is the increase as in older flies, in older stem cells. The mitosis goes up, more stem cells, we have more stem cells, second graph. And the third graph, more importantly, is that also the mitosis per stem cell goes up. So every stem cell is more active. Not only we have more stem cells, but every one of them is more active too. And another interesting feature is that why are these stem cells more active? At least one reason is that when they cluster, they help each other, probably because they produce cytokines and growth factors, which spread to each other and they help each other undergo mitosis. So you can see that the more the bigger the clusters of stem cells, the more mitosis each and every one of them has. So clusters of a lot of cells have a lot of mitosis, not because the cells are a lot, but also each one of them is more active. Another interesting feature is that we can stop that through chemotherapy drugs. I'm not insisting that we should be taking chemotherapy drugs in a very young age, but doing so, it reduces the clusters. We gave rapamycin, for example, and fluoxuridine. Fluoxuridine is just for 5 days in the beginning of the fly's life, and these tend to reduce the mitosis and the clustering in the colored bars over there. Reduce the clustering, and interestingly, the effect is stronger if you provide the treatment in young flies as opposed to older ones. Now, what is the basis of that? I described some features, some impact. What is the base of that? We think that the tumor suppressor gene, NOTS, is a very conserved gene. In this case, it acts as a tumor suppressor, so when it's mutated or when it's lowly expressed, stem cells overmultiply, for example, and they lead to tumors. And one feature is that the posterior midgut, especially that of females, is overactive and produces many of these abnormal stem cells, and it's in this part of the female gut that NOTS is lowly expressed. So NOTS has to do with that. We try to explore more. We devised a tool, it's blurred over there, doesn't matter. So we made a detection system that GFE goes up if the overall locus, NOTS locus region goes down. So whenever there is genetic instability that blocks that region, the GFE goes up. And we see a high correlation between the stem cells, the number of stem cells we see in the gut, and the GFE marker that lights up, and also different levels of NOTS itself. It's not stable, but some cells express more of it and some less. So there is an instability also in very young flies. And this, oh, again, this is blurred. We notice a lot of differences in tumor formation. Now I'm not talking about aggregates, but bona fide tumor formation, which is caused by mutations in tumor suppressor genes and make massive tumors in the fly gut. Very similar to what might be happening in mammals. And we see that different genotypes, these bars over there represent different genotypes, have different percentages of such tumors, and the different regions in the gut, that's the pie chart, have different frequencies of that, in quite fair analogy with what is happening with the human gut. And in the bottom graphs, although they are blurred, pretty much there is a tight correlation between the clusters a young one exhibits and the tumors that they develop in old age. So yes, these clusters can somehow predict the old age bona fide tumorigenesis. And this is just one slide to say why this might be happening. It has to do with DNA replication stress. So the more mitosis, the more DNA replication stress you have. And we have the red marker for this over there. So when we create these tumors, either intentionally through genetics, that's the upper graphs, or spontaneously. Underneath is a spontaneous tumor that happens spontaneously during upon aging. DNA stress is increased in these cells. And importantly, if we have aggregates of stem cells next to the tumor border, these are more stressed too in terms of DNA replication stress. And the farther away they are from the tumor border, the less stressed they are. So definitely we have a lot of DNA replication stress inside the tumor, but also in clusters of outside the tumor that generally predict tumor formation. And they are not mutated yet, but eventually they become. And that's the final slide pretty much. The model is like this: a young stem cell, or a stem cell in general, has some signaling instability in tumor suppressor genes, in this case NOTs, and along with mitogenic factors, and these can be many, can be sex, can be drugs, can be diet, can be, we tried many different things that affects mitogenic process, and it affects this process in general. This leads to increased DNA replication stress, more mitosis, more replication stress if you force the system to divide too much. And then we have these abnormal cells that are hyperactive. They group together and they're hyperactive, they are stressed, and they produce more of these cytokines that accelerate their pace. What we don't know is the last part, is that how this leads to DNA mutation, how this increases the frequency of DNA mutation, because we know it happens, but we don't know the mechanism by which this specific thing is happening. And we are very eager to answer that, because that's a universal question, I think. And with that, I would like to stop and thank the people, especially the three people in the top, Konstantina, who is doing her second postdoc now at UCY, Sava Stelloni, who is in the audience and is now in the SINS, Cyprus Institute of Neurology and Genetics, Maria Koumouri, who works now in CCRI, Cyprus Cancer Research Institute, and thank you all for your attendance.
Thank you very much for this very interesting presentation. Are there any questions from the audience? Yes, there's a question over there.
Very, very impressive presentation. I'm fascinated. I love Drosophila, the fruit fly.
Thank you.
I'm mainly interested in the antenna of the Drosophila, because it's very interesting protein, antennapedia, which I will talk a little bit later on. But you are saying the intestinal stem cells of Drosophila have some unstable flows to start with, and that eventually,
yes,
presumably, that's the mechanism that Notch switches on at some point. As you know, Notch is an important mutation in human cancer.
Yes.
The question is really, does the human intestine is equally flowed as the Drosophila, and could that be another mechanism for that?
That's the assumption that we have, but we have no proof of that, because we study flies in order to find new concepts, basic concepts, that some of them might be preserved in humans, considering the overall analogy of organs and cells and signaling pathways.
Because
so
people use Notch inhibitors, as you know, for cancer treatment, and some of the Notch inhibitor side effects is significant small bowel toxicity. So obviously the anti-Notch drugs can be toxic to normal bowel in humans. I don't know if that is very keen. You haven't worked with John Astor at Harvard?
No, I haven't worked with mammalian stem cells, although we do preventive medicine in humans now in Cyprus. So yes, the equivalent systems might work in humans, but first we need to establish that through basic research, move on to human cell lines, and then try to apply it to humans. So the answer is, it would be very interesting to explore that area.
Very exciting work.
Thank you very much.
Thank you very much.